After completing this lesson, you will be able to list 5 examples of common misperceptions about newborn feeding, which interfere with the establishment of exclusive breastfeeding. We are going to begin with the assumption that exclusive breastfeeding is effective and it provides everything an infant needs. Beginning with this premise, this is the appropriate premise scientifically and physiologically. This allows the lactation care provider to view the breastfeeding situation through the lens of normal and to identify risk factors. Now, most mainstream conversations about breastfeeding imply that it is not enough or even unsafe. There is messaging out there in the world that implies that it's unsafe to rely on exclusive breastfeeding. However, the evidence base for the Baby Friendly Hospital Initiative is vast. The practices promoted in the Baby Friendly Hospital Initiative are well established. They are well proven to be effective. The theory of physiologic plausibility affirms that exclusive breastfeeding is the logical and safest method of feeding for a newborn infant. Now, physiological plausibility simply means that when we consider a health behavior or a piece of research, that it needs to make sense based on the biology of humans and what we know. And what we currently know about the way that newborns establish their transition from the womb to the world is that exclusive breastfeeding is the safest and most effective way for them to do that. And that interfering with exclusive breastfeeding can result in outcomes that we don't expect and outcomes that are negative. Common obstacles, things that do interfere. When parents are working to establish exclusive breastfeeding in the hospital, many things can come up that can interfere with their desire, their plan. Now, if the baby acts very sleepy, if the parent is very sleepy, due to any number of factors, but can include things like just a very long labor, a very difficult labor, or using pain medications. Some pain medications cause more sleepiness for mothers. They need them and they do make them sleepy. And so sometimes this results in this excess level of sleepiness that can interfere with how frequent feedings are happening, or feedings are ending earlier than what the baby intends because the baby is tired or the mother is tired or both of them are tired. So this can interfere with what we've talked about is the most important thing, early and frequent feeding of babies according to what the baby is actually asking for. Now, latching difficulties and pain or nipple trauma, these can also interfere with exclusive breastfeeding. Jaundice or a rising level of bilirubin, this can interfere if the interventions undertaken are not promoting continued breastfeeding. Infant weight loss beyond what's expected can cause lots of concern and sometimes cause people to intervene in ways that, again, leave breastfeeding behind. Pain and fatigue on the part of the parent are extremely important to understand, to recognize, acknowledge, and manage. And they also can sometimes interfere with the establishment of exclusive breastfeeding. Maybe that's completely rational and that's completely needed, but we have to recognize that sometimes things are not ideal, right? And if they have a lot of pain, it still may interfere. It's not their fault. It's not anything that we can really change. We have to address it, we have to manage it, and we have to accept that it may interfere with the establishment of exclusive breastfeeding. That doesn't mean it always will, but it can. And we need to recognize that when it's happening so that we can not allow people to think that it's their fault. And of course, low blood sugar is something else that can interfere with exclusive breastfeeding. Again, sometimes that's necessary, and sometimes it's the interventions that are undertaken are not ideal or optimal to preserving the ability to continue breastfeeding. Common misperceptions that come in sometimes with families. whether that's with the parents or with the people who are coming in to support them, their own families. A lot of times they come in with these beliefs already in place, that there's no milk when the baby's first born, that babies should eat and then sleep, just go to sleep and they won't wake up again until it's time to eat again. Time limits on feedings or specific time intervals between feedings, that you need to use a pump to get milk out, that other caregivers need to feed the baby, that a baby losing weight always means that breastfeeding isn't going well, that they need to know exactly how much milk is getting into the baby, or that diapers are a direct reflection of the baby's intake in the newborn period. Now, these are all misperceptions. These are all wrong. They're not correct. They are beliefs, they are opinions, and some of them are scientifically inaccurate. And what we want to remember is that healthcare providers themselves also may not have had appropriate education about these beliefs or perceptions, or they may use their own personal experiences with breastfeeding their own children as the measuring stick that they're comparing this baby to. So all of these things need to be addressed in the education that we provide, but they also need to be addressed directly as they come up so that the information we provide is tailored to the specific situation and parents can integrate it into what they are doing with their own baby. More misperceptions that can interfere are going to be things about birth interventions, that they have no effects on babies or on birth parents, that if they're considered safe, they would have no lasting effects on either one, that preterm and late preterm infants are just smaller than term babies and they have basically the same needs, that preterm infants must show that they can bottle feed in order to go home, that formula will fix a breastfeeding problem, that a small amount of formula is not risky or doesn't have the same risks as if you give a lot of it, or that a pacifier is not going to interfere with breastfeeding or may even make breastfeeding better. I've got more. We can go on all day, right? Another misperception that can interfere, and this is a common one for families to bring in among their own beliefs, is that the baby is using the breast as a pacifier, that crying is a hunger cue, that they should wait until the baby cries to know when to feed the baby, that babies should sleep very deeply for long periods of time, that is the goal, that frequent feedings mean the baby is not getting enough milk, that babies are born really hungry, that there's no milk in the breasts until the breasts feel full or leak. Now, it also could be that people believe that infant suckling is not important, or it can be replaced with a pacifier providing no nutritional value. These perceptions really make a difference. These misperceptions really make a difference, because if they cause interference and intervention to happen that is not supportive of exclusive breastfeeding, then they can be something that interferes and makes it difficult for breastfeeding to continue or even compromises milk production. Now, when we think about these common obstacles and misperceptions, what happens in a parent's mind? And when I use the term parents, I'm talking about all parents. I'm not talking about only the person who gave birth to the baby. I'm talking about partners who are parenting, talking about everybody who is parenting a newborn. All of these misperceptions, all of these thought processes interfere with what ends up happening with the feeding of the baby. So there's a lot of research on the concept of breastfeeding self-efficacy, which is essentially like talking about the confidence that a mother has that she can successfully breastfeed. There's certain elements to it. There are validated research tools that can be used to assess it, and we know a lot of interventions that can improve breastfeeding self-efficacy. And the first 100 hours process here is designed to help improve breastfeeding self-efficacy as well. But we want to think about what these misperceptions can do to someone's breastfeeding self-efficacy. If they already have low breastfeeding self-efficacy, they already feel as if they are not going to be able to breastfeed successfully or meet their own goals. And then they meet common obstacles to exclusive breastfeeding, like difficulty latching, or jaundice, or early weight loss, anything like that. When those things all get together, what happens is that parents start to hear and sense and perceive that breastfeeding is usually or always problematic. It's going to be too hard. It's going to be very hard. It's going to be challenging all the time. It's going to be challenging forever for as long as they do it. They also can mistrust the process of breastfeeding. They don't understand how it works. It's very easy to mistrust the process. If you believe that frequent feeding in the newborn period means that the baby is not getting enough milk, of course you're mistrusting the process. You don't understand why the baby needs to go to the breast so frequently. It seems like that signifies a problem. So you're mistrusting that breastfeeding can work or be effective. All these things together combined can lead to overreaction, more intervention than is necessary, and especially to the unnecessary use of formula during this critical beginning time of breastfeeding. This can lead to erosion of how the mother feels about her breastfeeding self-efficacy, her confidence that she can breastfeed her baby. And this is what we're trying to avoid. We're trying to make sure that people have not only the information, but the experience in the first 100 hours that allows them to feel confident that they can continue to breastfeed. This is really key. This is what we are trying to put together through this whole concept and this whole strategy. It's important for us to keep in mind that several generations of healthcare professionals have little to no formal education about human lactation. This is not a blame game. This is not this person or this type of healthcare professional doesn't know anything about breastfeeding. That is not at all what this says. What it says is that research has shown us that many types of healthcare professionals receive little to no formal lactation education, and they have little to no experience with exclusively breastfed or exclusively breastfeeding patients. They don't see it frequently enough to be getting information out of the process. They didn't learn enough in their formal education to understand the process. Sometimes they can display little to no trust in the process of exclusive breastfeeding simply because they've never or rarely seen it work. What they've seen are the challenges that show up. They may have felt the frustration of all of the mothers that they've seen struggling with breastfeeding. They may be acting out of a desire to bring down the burden. They may not know what to say in those situations, but their mistrust in the process of breastfeeding means that any problems that come up and any problems that they are looking for are going to automatically require formula as an intervention. And I would add that in the modern day, in the United States, where pump use is very ubiquitous, many people use them. Most people acquire them because they are required to be provided by a law. Breast pump use sometimes becomes that other intervention that is used as a blanket solution for everything. So we have to keep this context in mind and understand where people are coming from when they're trying to help on the lactation journey, what their background might be that they're bringing to the table, and why they're trying to help in these ways that we may know can interfere, but they feel are going to be effective and may not understand the entire context of how those interventions may play out over the long term.